So our grand round speaker today is Dr. Mauro Salifu. Since I have come, I have noted that I have a true partner in medicine, and you cannot take that for granted. I have been at institutions where medicine and surgery constantly were fighting to the detriment of the entire institution. Dr. Salifu and I share a common interest, that is transplantation. Dr. Salifu is chief of the division of nephrology and the medical director of the transplantation service, aside from being the chairman of the Department of Medicine. I won't go in detail over his CV, which is very impressive. He has published between 100 and 200 peer-reviewed publications, but above all, he is an extremely accomplished researcher, having NIH grants both for basic science research as well as for clinical and translational studies, and he has accrued over the years 8 figures in terms of NIH money, which, as you know, is a very rare commodity these days, particularly if you're a chairman. He's going to talk to us today about one of his research projects, which has implications on the treatment of atherosclerosis, thrombosis, and other vascular diseases. He's going to talk to us about, and I have to read it because I'm not familiar with it, about the role of F11R antagonists in neoentymal hyperplasia in dialysis vascular accesses. That is important for us because we have one of the most active vascular access programs in the borough, maybe even in New York City, thanks to Dr. Dale Distant. And again, we have to make changes and improvements on many fronts in that regard. As you know, our patients frequently end up with thrombosed grafts, so we have to look for improvements in that regard, and Dr. Salifu will address these issues. Thanks again for coming, Mauro.
My task today is to share some very interesting research with you that is happening here at Downstate. Very, very interesting. And it has to do with a receptor that we discovered, cloned, and sequenced many, many years ago. And it has now evolved into the field of atherosclerosis and vascular disorders. And I'm going to be sharing that detail with you. So we discussed some few things in the trends, how the vasculature, that is venous system and the arterial system, have problems. And then we will discuss some of the research that we've done and then the role of the F11R receptor in that regard. The number of ESRD patients in the United States is increasing. You all know that. In 1972, when the Medicare program approved the payment for dialysis, there were only about 50,000 patients. The expectation was that in the next decade from 1972 to 1982, we will not have more than 50,000 patients. But right now, we have more than 400,000 patients on hemodialysis and about 186,000 patients who have a transplant, for a combined total of close to 600,000 patients with ESRD. That is huge, and it continues to go up. The best option for hemodialysis is a fistula. Of course, if you can't get a fistula, you can put an AV graft, arteriovenous graft, but the fistula is really the preferred method to deliver dialysis. And this is a patient with radial to cephalic fistula. It's well dilated, very nice. Patient is well positioned and is getting good dialysis. So the access is the Achilles heel for hemodialysis. Without the access, it's not possible to provide the level of clearance that we need in order to guarantee the patient will survive long term. But these accesses don't last too long, and that has been a challenge. For instance, most patients with AV fistula would need an intervention at least 2.5 times in a year. That is a lot of interventions just to maintain patency for the access for the patient to be able to get dialysis. And so the better the access, the more the access can survive without intervention, the better the clearance, and of course, the better the survival of the patients. This is an example of a fistula, right? You have the brachial artery coming down, you do your anastomosis, you hook up the arm cephalic vein to the brachial artery, the blood from the brachial artery flows into the arm cephalic vein, the vein dilates, you get a fistula, very nice. But if the patient doesn't have the appropriate vein size, and what we mean by that is if the patient's vein size is less than 2.5 millimeters in diameter, it's not possible to make this anastomosis. If you can do it surgically, but it may not mature, right? So we tend to want the vein criteria to be 2.5 millimeters or more for us to get a very good fistula, to be able to get the fistula to mature in the right time, usually around 6 weeks' time, for dialysis to happen. On the other hand, if the vein size is less than 2.5 millimeters, of course, you can put your PTFE graft or some other graft material, you hook it up to the brachial artery again, you bring it to the more proximal veins, and you hook it up, you do your anastomosis, and the patient has a conduit for dialysis. This is all acceptable. The problem, though, is if you put a fistula, a lot of them would fail. Within 2 months of placing the fistula, 25% of them will fail. And 50% of them will fail in 12 months. That is a huge, huge issue. In the days that I was trained as a nephrology fellow, the patients had multiple surgeries just to get one access matured to be able to do dialysis. At least in today's world, we have interventional procedures that can help the fistula to mature a little bit better, but it's still a problem. 50% in today's world would fail within 12 months, require multiple surgeries. So that's not fun at all. So the question I have for the audience is, what is the fistula failure rate? Why is the fistula failure rate so high? Why do we have this so high? Is it because of smooth muscle cell proliferation and migration from the media into the intima, obstructing the lumen? Is it because of atherosclerosis of the venous side? What is it? Or both? Somebody said both. So let's take both, and let's see what the answer should look like. For the most part, the problem is called neointimal hyperplasia. We abbreviate it as NIH. It's defined by a complex process of smooth muscle cell proliferation and migration from the media. You all know that the vessel wall has 3 layers, right? The adventitia, the media, and then the intima. So there is movement of these muscle cells, smooth muscle cells from the media into the intima, along with apoptosis and matrix deposition. So with time, the lumen gets more and more obstructed because of the intimal disease. The lumen gets smaller and smaller. It actually begins when the patients have CKD. So it's not a problem of the creation of the access itself. The vessel wall is actually damaged at the time that the patient has CKD, and it gets worse when the patient actually develops ESRD. So as an example, this is the renal artery here. You can see that these are the layers, adventitia, this is the media, which is usually very thick and nice, and you have a very tiny intima. When there is CKD or CKD sets in, the intima begins to get thickened and the media gets smaller. This is human tissue. So it is real, and I'm going to show you a few more slides on how this disease develops. So in the past, we thought that the movement of smooth muscle cells from the media to the intima can be treated with things like Plavix, anticoagulants, antiplatelet agents, but no, it doesn't work in the venous system. Because the neointimal hyperplasia in the venous system is not the same as atherosclerosis. In atherosclerosis, you have an eccentric lesion. You have a plaque. The plaque has cholesterol and all the macrophages, foam cells, and the rest of the lumen is okay, actually. It's eccentric, just one-sided. In neointimal hyperplasia, the smooth muscle cells are moving from the media to the intima in a concentric circle. So the entire lumen is occluded in a concentric way. This is the media, and now this is the thickness of the media. So with time, the media gets bigger and bigger, the lumen gets smaller and smaller. And that's what causes the venous stenosis in patients with a hemodialysis vascular access. That is the lesion. So the lesion in hemodialysis is not, vascular access is not atherosclerosis. It is a different disease, and we call that disease neointimal hyperplasia. This is a cartoon that shows you how that works. You see the smooth muscle cells in the media, they move into the intima, and they cause accumulation of these cells in the intima, and of course, with time, that occludes the lumen. Some time ago, we did a study looking at where is the actual stenosis. And the stenosis can be found anywhere. The stenosis could be at the anastomotic segment, it could be in the body, it could be the venous outflow, it could be the central venous system, it could be anywhere. It is very difficult to predict where the stenosis is going to be, right? As an example, you have the brachial artery coming down, you created your fistula at this segment, The surgical injury at this segment can cause inflow stenosis, for instance. As an example, the patient had a fistula, this is an outflow stenosis in the axillary vein, right? So it's very hard to actually predict where the venous stenosis is going to happen. So the question is, why does it happen in the first place? What are the mechanics that actually allow the venous stenosis to happen? So this is what happens. So when you create the fistula, this is what you're doing. You're connecting the vein to the artery. The blood flow in the artery, which is about 140 or above, over 90 and above, that's very high pressure in the arterial system, suddenly gushes into the venous system. So that induces a number of things. It induces flow problems, it induces pressure problems, and turbulence issues in the venous system. And the vein begins to react. The vein then senses the smooth muscle cells in the adventitia and then the media, sensitizes the pressure, the flow, and all the dynamics that are happening, and they begin to proliferate and then migrate into the intima. The intima becomes bigger and bigger, and thereby occluding the lumen, as you can see here. So there are upstream events that are the hemodynamic issues related to flow, pressure, turbulence. They may be good or they may be bad. We have surgical injury, which is definitely bad. We have the cannulation injury, which is definitely not a good thing. You have uremia and all the other stuff that are also adding to the vessel wall injury. And then you have the downstream events that are more related to cytokine activation and proliferation of the smooth muscle cells. Those are related to things like oxidative stress, nitric oxide, the growth hormones, and all the other biochemical stuff that happens over time. So in the resting state, it's amazing. In the resting state, the smooth muscle cells don't really do too much, except responding to constrictive stimuli, like adrenaline, norepinephrine. In the resting state, look at this as the smooth muscle cell membrane. All the receptors are preoccupied with the matrix protein, so they are not exposed. So the cell is just lying down, only receiving one or two stimuli to be able to constrict, right? But it doesn't receive any signal to generate biochemical signals. In the activated state, though, when the smooth muscle cell is activated, all the matrix proteins separate, now exposing the receptors on the cell surface of the smooth muscle cell, then allowing the signal to come through. That is what we think is a model for the smooth muscle cells receiving the signal and now beginning to proliferate and migrate. I have a question for you just to stimulate your attention. So the question is, based on what we know right now, do antiplatelet or antithrombotic therapies prevent neointimal hyperplasia and access failures? Is it a yes? Okay, so the answer is definitely no. Okay, very good. You're listening. So all the antithrombotic, antiplatelet therapies so far have not worked in the venous system related to hemodialysis vascular access. None of them. And as examples, there's a big study here from the NIH that looked at this issue, thrombosis at 6 weeks, no significant difference. There was another study just as big using Agranox, dipridamol plus aspirin, same thing. They couldn't find any difference. So right now, the only thing that is available to these patients is, and you all know that, the patient has thrombosis or stenosis, the patient goes to IR, gets the angioplasty done, and after the angioplasty, so what? Right? Each time you actually do the angioplasty, you are actually causing more injury to the vessel wall because that's another stimulus. So the angioplasty itself is just mechanical. It just makes everybody happy. You get a very nice result, right? So here you have a stenosis. You put a balloon, you get an angioplasty. You do your post-angioplasty imaging, very nice result, and everybody's excited. But this is actually more injury to the vessel wall because it's going to come right back in the next couple of months, and you have to do it again and again. So that's where we are with dialysis access stenosis. They come in, they have the intimal disease. There is no mechanism to prevent it from happening. We mechanically just blow it up or surgically do some reconstruction. The patient comes back in another 6 months, and we do exactly the same thing. That's where we are. Okay? So what is in the pipeline? So we think that novel therapeutics should address the pathways. And that has been part of my research. We have to really address the pathways that can limit the proliferation of these cells and should prevent them from moving from the media into the intima. That has always been the goal. So Sometime in 2000, my lab and other group, we discovered a receptor that we named the F11R receptor. We cloned and sequenced the receptor. At the time, we didn't know what the relevance was going to be, but it was very, very present in platelets. You can see the staining here, very nicely located on the platelets. We found that it was on the endothelial cell. This is an endothelial cell surface, and the receptor is taken out this way, right? And this is a platelet membrane, and the receptor is taken out. So we found that the receptor was both on the endothelial cells and also on the platelets. And we felt that that was the mechanism by which the platelets are actually attached to the vessel wall. That was the first discovery. And this was published widely around the globe. Subsequently, we did some animal studies that showed that if you took ApoE knockout mice, these are mice that spontaneously develop atherosclerosis, you can actually see the expression of the F11R in these mice, as you can see here. Nice expression over here. Then we took human tissue. We went to the cath lab. The surgeon gave us nice pieces of atherosclerotic plaque tissue. We stained it, and then you can see very nice staining of the F11R. We stained it too with endothelial markers like VWF, von Willebrand factor, and it's colocalizing very nicely. So it means that the F11R and endothelium are colocalizing at the same point. This is the plaque, and this is the endothelium, and this was very nicely expressed in that area. And this became a very big publication and read widely around the globe. So we then started thinking, what is causing this expression in the plaque? Obviously, even in atherosclerosis, it's just not just the macrophages and the cholesterol crystals and the foam cells. There is also migration of smooth muscle cells from the media into the intima, even in atherosclerosis. That is also happening. So we began to now explore what is the role of the smooth muscle cells in atherosclerosis itself. That contributes to the migration of these smooth muscle cells. Here you can see in the smooth muscle cells, that we were able to incubate. You can actually see that if you activate the smooth muscle cells, you can see expression of the F11R in 24 hours and also in 12 hours and also in 24 hours, which was the first signal that showed that the smooth muscle cells actually expressed the F11R. And once we found this, we knew that there was an opening for vascular access for the future. So the next experiment was, now that we know that the F11R is expressed in the smooth muscle cells, if we knock down the F11R gene, can we prevent the expression of F11R? That was the next question. Because if we could do that, then potentially any mechanism that you can use to suppress the F11R receptor, you should be able to prevent the smooth muscle cells from migrating and proliferating. So that's exactly what we did. So we knocked down the smooth muscle cells, the gene for the F11R in smooth muscle cells, and this is the cells. This lane is the cells that we didn't knock the gene down. And if you can see very closely, this is a Petri dish, by the way, with a glass slide, Petri dish and glass slide. This is the lane that we didn't knock down the F11R gene. You can see these lines. This is just to magnify it for you. At 24 hours and at 48 hours, the smooth muscle cells actually will continue to proliferate and migrate, right? You can see more of the lines here, which means there is more cells in this lane here at 48 hours. But if you knock down the F11R gene, that is this lane, you can see very few in 24 hours. And certainly in 48 hours, you don't really see much cells in the Petri dish. The cells just stop moving. So this was the first evidence that if you actually knock down the F11R gene, you can prevent the migration of smooth muscle cells at a very, very high rate. 70% of the smooth muscle cells couldn't migrate. And this is the quantitative analysis showing the same thing. What about proliferation? Same thing. When you knock down the F11R gene in these smooth muscle cells, the smooth muscle cells do not proliferate. They proliferate, but at a lower level. 35% will not proliferate, which is very good, as opposed to if you don't knock down the F11R gene. So we're able now to establish that if you knock down the F11R gene, the smooth muscle cells do not migrate at a high level and moderately do not proliferate as well, which are two important findings based on the pathophysiology of what I explained already. So this is very relevant. So the next question is, now that we know that this is the migration is very related to F11R action, the question is, where does it come through in terms of the smooth muscle cell? Where will the signal come through? As I said, the smooth muscle cells, when they are not activated, they are covered by all these matrix proteins. When they're activated, the matrix proteins move, the receptors are exposed. One of the most important receptors is called the beta-1 integrin receptor. That triggers the beta-1 integrin pathway for signal transduction. So if you're able to show that the signal is coming through beta-1 integrin pathway, that is really relevant to our research. So that's what we wanted to establish here. And that's exactly what we did. Again, this is the first set of experiments to illustrate that point. Whenever you see these kind of blotting images, don't get confused. This is just qualitative, just to let you see whether something is happening or not happening. And then we do really quantitative measurement to actually see the actual numbers. So just follow me just a little bit. So this is F11R, right, at 0 hours, 24 hours, and 48 hours. And you can see the expression of F11R. You can actually visually see it's coming up. And the beta-1 integrin is also coming up nicely, right? Tubulin is just a control to make sure that the experiment is actually working okay. So tubulin expression is good, so which means that this experiment is very good. Now this next lane shows you what happens when you knock down the F11R gene. Does it also knock down the beta-1 integrin gene? That's what we are trying to illustrate. So here, this is the usual F11R, the beta-1 integrin, and the tubulin are all expressed. Now, if you knock down the F11R gene using this is the siRNA, you see that the F11R goes down, the beta-1 integrin goes down, and the tubulin remains the same. And that was the first time we were very, very encouraged that the action of F11R likely is going through the beta-1 integrin pathway. And this is just basically the same thing, but quantitative analysis, looking at the same thing. So again, this is the model. When this is the cell surface, you have the receptors, and they are covered by these extracellular matrix proteins. And if the cell is activated, these ones will shift, and something will bind. And that's exactly what it is. So when the cell is activated, the F11R can now be activated, as we showed in the few slides. The F11R now binds to the beta-1 integrin and then causes the signal transduction downstream within the cell. So this is our working hypothesis for the F11R involvement. So the next question is, can we identify peptide inhibitors? Now that we know that we have settled on the mechanism, can we now identify something that can block the mechanism? Because obviously, if you can block the gene, that would be the ideal. But nobody's going to block the gene ever, because then you're going to block all the genes in cells all over the place. And that is not going to be viable. But if we found something that can block the receptor at the cell surface level, then we have something that we can use, right? So we did some additional studies looking at the F11R, the receptor itself. We pieced the F11R and took the active domains and changed them a little bit to inhibit the F11R receptor. And we found really very good candidates. We found candidates, we labeled them peptide 1 and peptide 4 and peptide 5 that can actually inhibit the peptide, the F11R receptor. So this kind of technology is very interesting because you can take a receptor, take the active domain of the receptor, modify it, and put it back in the same receptor until inhibit it. This is called competitive inhibition. That's what we did in this experiment. So it's a fragment of the same receptor that is inhibiting the receptor, keeping it busy so that it cannot transduce any signals. And that's what we did. And we found a number of candidates, P1, P2, P4, and P5 genes. And this was published in Science. This was the first time we realized that you can actually have peptide inhibitors for the treatment of atherosclerosis and intimal disease. This is the paper. This was 2014. Yeah, it's okay, 2014. There's an error in the type. I wasn't born yet. I was in diapers. That's correct. Okay, so then this made it to become a patent, and this is now big stuff all over the country. Everybody wants to know what peptide 4D is, what F11R receptor is, so this is big stuff. Anyway, the next question now is, will these peptide inhibitors, because we have to do more research now in animal. Now we have the in vivo studies. We are very happy with the in vivo studies. Now we have to move to animal studies, right? So the next question is, these peptides, will they work in an animal model? That's the next question. And that's exactly what we did. We took the peptide, one of the peptides, we interacted with the F11R, and there's very nice inhibition, very nice inhibition. And if you look at the mouse proteins, do they interact with mouse proteins? And there's a very nice interaction with mouse proteins, which means that we can now do experiments on mice to determine whether we can treat those animals. So right now, this is a working hypothesis. Our peptide would sit in the middle of the F11R domains, prevent the F11R from coming together and transducing the signal through the beta-1 integrin. Therefore, the cell should not proliferate and should not migrate from the media to the intima, hopefully. So, now that we have all the information we need, now the next step is conduct the animal experiments. So we took a number of mice. These were uremic mice that we were able to induce. There's a way to induce uremic rats and mice, but we chose to do uremic mice. This is the model. You take the mouse, you dissect the carotid artery out, you ligate the carotid artery, and then with time, the area of ligation will develop intimal disease. So we wanted to know whether if we treated this intimal disease with our peptide, you can actually prevent intimal disease in those animals. So that's the model. So the first experiments took about 7 mice each to just assess the conditions of experimentation. We did 14 days, 21 days, and 28 days of ligation to see at what point do you have the maximum intimal disease before we began to do our experiments. And what we found was that in the beginning, of course, this is the lumen of the carotid artery. In 14 days, the intimal disease begins to form. By 21 days, the intimal disease is maximal. And by 28 days, it's basically the lumen is almost occluded. So we chose to do our experiments on 21 days to see whether we can prevent the intimal disease in 21 days. So this is the 21-day period. This is a control, right? So we injected a number of mice with the peptide 4D for 21 days, because now we have evidence that 21 days is a better day. And the second set of mice we injected with saline and sham for another 21 days. And then we sought to find out what happens to these mice when you inject them with the peptide. There's a timeline. We created we removed 5/6 of the kidneys. So these were actually uremic mice by 8 weeks. So you can take them, you open the kidney, you just shut down a portion of the kidney, and you close it back. Then you monitor them for 2 weeks. If they don't die, and luckily enough, none of our mice died, we did the experiments. You open the carotid artery, you ligate the carotid artery, the left side, and then we treat them for 3 weeks. That is now 13 weeks. And all of them survived. Most all the mice survived in this experiment. This is what I showed you as the control in 21 weeks. If you give the peptide, this is what you find. There's luminal reduction. The lumen that is reduced here is much, much open here. The intimal disease that is thick here is much, much less when you treat the patient, not the patient, but the mouse at 21 days. And this is the contralateral, that is the opposite side of the body. You cannot ligate the two carotid arteries at the same time, because if you do, the mouse basically is dead or will have a stroke. So usually you can only choose one side to ligate. So this is the contralateral side, which doesn't show any disease at all. In terms of measurements, you can see that if you analyze the intima to the media ratio, you can see that the controls have higher intima to media ratio compared to the peptide-treated mice, and this was statistically significant. And if you do the pooled analysis of all the sections, if you take every single section that we ever did in the within the interval, 2 centimeters of the ligation, and take every single section, you pull them up just to see what happens. The pooled analysis shows that you still have higher degree of intimal disease in the controls compared to the animals treated with peptide 4D, which is very significant. And if you did the intima to media ratio, you did the same thing, but you pulled it up. You pulled up all the analysis and looked at the ratio itself, not the actual thickness, but the ratio itself, the intima to the media ratio. You see that the controls have a huge intima to media ratio compared to the animals treated with the peptide, and it was statistically significant. So this is where we are. We're trying to resolve that issue. The next step in these experiments will be to look at bigger animals. Our plan now is to go into pigs. We'll be needing the help of surgeons to create those fistulas, real models of AV fistula, trying to treat them to see whether peptide 4D can inhibit neointimal hyperplasia, so that we can get at least some pharmacologic maintenance treatment for these patients. They get angioplasty, then they get pharmacologic management, and hopefully the patency would be improved from the current 3 to 4 months to maybe 12 months to 24 months. So right now, to summarize, so neointimal hyperplasia is a major problem in venous and arterial stenosis as well as arteriosclerosis. So whoever said both is correct. I heard both in the audience at some point. There is no treatment right now, so everything is mechanical. They come, they get surgical revision or angioplasty, and that's it. There's no maintenance treatment. And hopefully these experiments would lead the way to finding the pharmacological maintenance therapy for that. We have already discovered the peptide. Peptide is doing well. We think that it has implications for even more diseases of smooth muscle cells that are beyond the venous system. And we can talk about that when you ask the questions. And our research would have to do big animal studies to be able to find a treatment for this. So I'll stop here. I made it short because of the time issues, but I think the points that I wanted to convey to you, I believe I have been able to do that. So thank you very much for the audience, for the attention.